Welcome to the deep dive. You know, usually when we talk about a medical diagnosis, there's this expectation of like absolute precision,
Oh, definitely.
almost like engineering. You break your arm, the X-ray shows a jagged white line, and the doctor just points at the screen and says, there it is.
Right. It's very binary, broken or not broken.
Yeah.
It's clean. And honestly, I think it's comforting. We like our bodies to be neatly categorized.
Exactly. But then you step into the world of internal female pelvic anatomy, and suddenly that pristine X-ray machine
Yeah.
feels like it's just broken.
Yeah, completely.
We're looking at this diagnostic landscape that is completely hidden from the outside, incredibly complex and fundamentally vital to everyday life.
And yet,
Yeah, if we're being honest, most of us have absolutely no idea what's actually going on inside there. So today we are centering on a core, deceptively simple question. How do you actually know if your internal pelvic anatomy is normal?
it is the absolute definition of diagnostic muddy waters.
Yeah.
Because normal in this part of the body is not just a single frozen picture. It is highly variable, and it changes throughout your life and even throughout a single day.
Right. Which is exactly why our mission for this deep dive is to take you on a guided tour of the clinical frameworks, the physical assessments, and, the high-tech imaging that medical professionals actually use behind closed doors.
The tools they use to map, measure, and basically diagnose the pelvic floor.
Exactly. We want to demystify all this heavy medical jargon so you can truly understand your own structural baseline.
And to do that, we are pulling from a really fascinating stack of sources today. We are looking at European medical imaging guidelines from the ESUR, historical vaginal palpation techniques dating all the way back to Arnold Kegel in 1952.
Well, 1952.
Right, and also the highly specific quantification systems used by physical therapists and gynecologists right now.
So if we are trying to figure out what normal is, where do we even begin? Because if the anatomy is hidden, how do you know if an issue is caused by an injury or if you were just, built differently from day one?
That is the perfect starting point. Because before we can even begin to understand how the pelvic anatomy might fail or weaken or drop, we have to look at how the house is built in the first place.
Okay.
We have to go way back in time to when you were an embryo.
Wait, really? We're starting in the womb.
We have to, because between the 6th and 11th weeks of gestation in utero, there are these two paired embryological structures called the Mullerian ducts.
Okay.
And in the absence of testosterone, these two completely separate tubes are supposed to migrate together, fuse right down the middle, and then the wall between them is supposed to just, dissolve.
Okay, and assuming that all goes according to plan, what do those two fused tubes eventually become?
They give rise to the fallopian tubes, the uterus, the cervix, and the upper 2/3 of the vagina. Yeah, it's a highly orchestrated process of fusion and resorption. But as we know, biology is messy.
Right.
When the fusion or the dissolving of that middle wall doesn't happen perfectly, it results in what we call Mullerian duct anomalies, or MDAs.
MDAs. I feel like I've never heard of this. Is this common?
According to the European imaging guidelines we reviewed, it happens in about 0.1% to 3% of cases.
Okay, so
So it's rare, but definitely not impossibly rare. And what's wild is that a lot of people have no idea they even have one of these variations.
wait, really?
Yeah, they're often completely asymptomatic, and they only discover it during an ultrasound for something entirely unrelated.
So if it doesn't cause symptoms, why does it matter? Like, why do doctors care if it's a little different in there?
Well, because it can drastically change how the uterus functions under pressure. The guidelines note that up to 25% of women with these anomalies will experience obstetrical complications.
Oh, geez.
Yeah, things like spontaneous abortion, preterm delivery, or other adverse outcomes. And the specific type of anomaly dictates the treatment, which is why radiologists rely on MRI to tell them apart.
Right, because they need to see exactly what's happening.
Exactly. MRI approaches nearly 100% accuracy for this because it allows them to look at the external fundal contour.
The external fundal contour.
Yes, essentially the very top outside roof of the uterus.
Okay, let me see if I can visualize this to make the geometry a bit more accessible. You think of the uterus like a house. The sources talk about a bicornuate uterus versus a septate uterus.
Right.
Would a bicornuate uterus be like a house built with two completely separate, distinct roof peaks? Like you look at it from the outside and it dips heavily right in the middle.
Yes. And to take that house analogy a step further, the radiologist is actually measuring the depth of that dip in the roof.
Oh, okay.
If the concavity, the dip between the two horns is greater than 10 millimeters, it's classified as a bicornuate uterus.
Got it. 10 millimeters. So what is the septate uterus then?
Sticking with your analogy, a septate uterus is like a house with one totally normal flat roof on the outside. But inside, somebody built a dividing wall right down the middle of the living room.
Okay, I
So
see.
the outside contour is flat or convex, but there's an internal partition.
Okay, but functionally, why is that internal dividing wall, the septum, so dangerous for a pregnancy? Like, why does that cause the 25% complication rate you mentioned?
It comes down to basic infrastructure. Just like a cheap drywall partition added to a living room won't have the heavy-duty plumbing or electricity of the main load-bearing walls.
Right, it's just kind of slapped up there.
Exactly. That internal septum in the uterus often lacks a proper blood supply. It's mostly fibrous tissue.
Oh, I get it.
So if an embryo tries to implant on that middle dividing wall, it simply can't get the nutrients it needs to grow, leading to a miscarriage.
Wow. That completely explains the why. And it also explains why the MRI measurement of that 10-millimeter dip is so crucial.
It really is.
Like, if a doctor knows it's just an internal wall, a septate uterus, they can go in and surgically snip it. But if it's a bicornuate uterus with two separate roofs, they can't just snip it because they're cutting right through the actual exterior wall of the organ.
Exactly. The precise geometry dictates the surgical approach. But, the developmental biology throws an even bigger curveball here.
Okay.
The sources point out that if a doctor finds one of these anomalies, they immediately have to go look at the patient's kidneys.
Wait, the kidneys. What do the kidneys have to do with the uterus?
MDAs are associated with renal anomalies 30 to 50% of the time.
You're kidding.
No. Things like a missing kidney, a duplicated kidney, or a kidney in the wrong place. And the reason why explains so much about how we are built.
Okay, I'm listening.
The urinary system and the reproductive system share very close embryological origins in early embryonic tissue. If there was a glitch in the software code for the reproductive tract during those early weeks, there's a massive coin flip chance the urinary tract got a glitch too.
That is mind-blowing. But let me ask you this. If they check the kidneys, do they also have to check the ovaries?
Yeah.
Because intuitively, the ovaries are literally attached to the reproductive system.
It's a brilliant question, but no, they don't. And it's a crucial distinction.
Why not?
Because the ovaries develop from a totally different origin in the embryo called the primitive yolk sac. So a person could have a completely divided uterus and only one kidney, but their ovaries will look and function perfectly normally.
Biology is just endlessly, wonderfully bizarre.
It really is.
Okay, so that establishes our structural blueprint. We know how the house is built, and we know there are variations in the foundation.
Mm-hmm.
But the ground underneath this house is constantly shifting.
Gravity always wins.
Right. Gravity is pulling on the pelvic floor every single day, not to mention the pressure of pregnancy or coughing or, heavy lifting.
Mm-hmm.
So if the house is built perfectly, what happens when the actual support structure gives way?
Well, that brings us to pelvic organ prolapse, or POP.
Mm-hmm.
And to understand prolapse, you have to visualize the normal baseline. The pelvic floor isn't a static bone. It's a bowl-shaped muscular sheet resting at the bottom of the pelvis. The main player here is a muscle group that stretches from the pubic bone in the front to the tailbone in the back.
And reading the sources, it's not a solid bowl, right,
Yeah.
because things have to get out.
Right.
It has 3 distinct holes in it called the levator hiatus to allow the urethra, the vagina, and the anal canal to pass through.
Correct. And when those supporting muscles or the ligaments attaching them weaken, the organs there holding up the bladder, the uterus, the rectum, they lose their support.
They just kind of drop.
Yeah, they drop down, bulging into the vaginal space and sometimes protruding completely outside the body. That is pelvic organ prolapse.
But here's where I get confused from a patient perspective.
Mm-hmm.
The sources note that the symptoms of prolapse heavily fluctuate.
They do.
Like you might wake up in the morning feeling completely fine, but after a long day of standing or running errands, gravity takes its toll and you suddenly feel this heaviness or backache or a physical bulge.
Right, because of the constant downward pressure.
So if I'm a patient and I go to the doctor at 9:00 a.m., I might look totally fine. How does a clinician actually diagnose something that shifts around so much?
That is the core clinical challenge. I mean, how do you measure a moving target?
Yeah.
This is why the medical field developed the POPQ system, the pelvic organ prolapse quantification system. It's a standardized physical exam that removes the guesswork by mapping exactly where the organs are positioned relative to a fixed anatomical landmark.
Okay, I looked at the Yale Medicine and Hedges guidelines on this POPQ system, and I have to admit, It looks like intense math.
It does look intimidating at first.
They are literally mapping the pelvic drop using a coordinate system. How does this actually work in practice?
So in the POPQ system, the clinician uses the hymen as sea level. That is the 0 point. Everything is measured in relation to that specific plane.
Okay.
And during the exam, they ask the patient to bear down. This is called a Valsalva maneuver, essentially pushing down like you're trying to have a bowel movement.
Right, to create maximum pressure.
Exactly, to see exactly how far the tissue drops under that maximum pressure.
Okay, I have to push back on this POPQ coordinate system because looking at the charts, it feels completely counterintuitive.
How so?
Well, if I log into my medical portal and see a bunch of negative numbers, my brain immediately thinks deficit or bad, like a negative bank balance.
Yeah,
But in this specific exam, a negative number is actually the goal.
I know, it feels backward. But in the POPQ system, a negative number simply means the tissue is safely tucked inside, above the hymen.
Oh, I see.
Yeah, a positive number means the tissue has prolapsed past the hymen and is protruding outside the body. And 0 means it's right exactly at the hymen.
Right, so the grid measures specific compartments. There's AAA and BA for the anterior wall where the bladder sits, A and B for the posterior wall near the rectum, and points C and D for the cervix or the top of the vagina.
Yes, and just to give you a sense of the math, the guidelines state that point by the bladder wall should ideally be above -1. Point C, the cervix, should be higher up, above -5.
But let's get to the why here. Why go through all this trouble? Why measure points A, and B to the exact centimeter? If a patient says, I feel a huge bulge and I'm in pain, isn't that enough to just treat them?
This raises a really profound issue in physical therapy and gynecology. The difference between subjective feeling and objective reality.
Okay.
A patient might feel immense localized pressure, but anatomically, they only have a very mild stage 1 prolapse.
Oh, wow.
Conversely, they might feel almost nothing, but structurally, things have shifted to a stage 3 or even stage 4, which is complete reversion, meaning the vaginal walls have essentially turned completely inside out.
Oh, my goodness. Okay, so feeling doesn't always match the structural reality.
Exactly. By using this mathematical staging, doctors can track changes objectively over months or years. If a patient tries pelvic floor physical therapy for 6 months, the POPQ tells the doctor if the tissue has actually retracted upward by 2 centimeters.
Or if the patient just happens to feel a bit less heavy on the particular Tuesday of their follow-up appointment.
Right. It proves whether the intervention is actually working structurally.
That makes total sense.
Yeah.
It takes human memory and subjective pain tolerance out of the equation.
Okay, so the POPQ system measures where the internal organs are hanging. But what about the actual muscles that are supposed to be holding those organs up?
Right, the beams of the house.
Yeah. If a roof is sagging, it usually means the support beams are compromised. How do they test the physical strength of the beams?
This is where we transition from the structural test to the functional test. We move from mapping the drop to assessing the muscle itself through vaginal palpation.
And what surprised me in the research was a source from 1952, Arnold Kegel, the literal namesake of the Kegel exercise.
The man himself.
His descriptions of palpation from over 70 years ago are still foundational to how this is done today.
Because the baseline anatomy hasn't changed. According to Kegel's historical notes, in a normal patient, if a clinician inserts a finger, the pubocosciatesis muscle should be able to contract firmly around the palpating finger.
Like a squeeze. Right. It should feel like a distinct, purposeful squeeze and an upward lift. But he also described what it feels like when things are failing.
Oh.
If the muscle is atrophic, he noted that the walls feel thin, the middle third of the vagina is roomy, and there is absolutely no contraction when the patient tries to squeeze.
It's a very vivid physical description. But wait, if I'm a patient and my physical therapist asks me to squeeze, my idea of a strong squeeze might be completely different from what the therapist expects. How do they standardize that?
They attempt to standardize it using something called the Oxford grading system. It's a 6-point scale from 0, meaning no contraction at all, up to 5, meaning a strong lifting squeeze against resistance.
But even with a scale, isn't that still just one therapist's subjective feeling on their finger? Like my 3 might be a different therapist's 4.
You've hit on a major controversy. The sources from the International Continence Society explicitly point out that there are debates over how reliable the Oxford scale is between different testers.
I can imagine.
It is inherently subjective, which is why some clinics use tools like a perineometer, a specialized manometer inserted into the vagina that actually measures the squeeze pressure numerically in millimeters of mercury.
Okay, so we have ways to measure weakness. But weakness is only half the story, right?
Yeah.
Because sometimes the muscle isn't just weak, it's physically broken.
Exactly. Sometimes the muscle undergoes severe trauma and physically tears away from the bone. This is called an avulsion.
An avulsion.
Right. And physical therapists can actually feel for the specific type of tear during an exam by assessing something called the levator urethra gap, or LUG.
Let's break down the LUG, because this sounds like something you could almost visualize. How do they feel a gap?
Well, when a clinician is palpating the muscle along the pubic bone, they are feeling for the attachment point. A normal gap will admit about 1 finger's width between the urethra and the insertion of the levator muscle.
Okay, 1 finger.
But if there is a full avulsion, meaning the muscle has completely torn off the bone that gap widens, it will be at least 2 fingers wide. The clinician can literally feel a distinct void, an absence of muscle where it should be securely anchored.
Let's put an analogy to this. Imagine a muscular trampoline. The fabric of the trampoline is your pelvic floor muscle, and the metal outer frame is your pubic bone.
I like that.
If the metal springs tear off the frame, which is an avulsion, the fabric is going to radically sag on that side.
Yes. And that sagging creates a very specific, measurable physiological effect that the research calls ballooning.
Ballooning.
Yeah, when those muscles tear off the bone, that central opening we talked about earlier, the levator hiatus, it physically widens and balloons out under pressure.
And how do they quantify that ballooning? Like, is it more math?
A little bit of math. They measure it by adding together 2 points from that POPQ exam, the genital hiatus and the perineal body. In a normal pelvic floor, the sum of those 2 measurements in 3D space should be under 7 centimeters. But if that sum stretches to 9 centimeters or more, it is considered abnormal ballooning.
Wow.
Furthermore, if they look at an ultrasound while the patient pushes down and that hiatal area expands to 25 square centimeters or greater, it is highly indicative that a major trauma or avulsion has occurred.
25 square centimeters. That the muscles are just stretched completely beyond their functional limit.
Exactly.
What actually causes that kind of violent tearing?
The sources are incredibly clear on this. One major study noted that a primary risk factor for this kind of levator trauma is a forceps delivery during childbirth.
Forceps.
Yeah. In fact, nearly 21% of the patients in that study who presented with trauma had a history of a forceps delivery.
Why forceps specifically?
Because of the immense biomechanical load. The pubovisceral muscle is the innermost part of that muscular bowl. It sits right where the baby's head passes.
Oh, I see.
So when forceps are used, the sheer physical space required, combined with the rotational force to extract the baby, it just stretches that specific muscle beyond its tensile capacity.
That sounds intense.
It is. And modern MRI allows us to see this clearly now. We can actually view the increased fluid and edema in the muscle and pinpoint exactly where it gave way.
So we have covered a massive amount of ground today. We've talked about the embryological blueprints and dividing walls, the highly mathematical POPQ coordinates and Valsalva maneuvers, the 1952 palpation tests, the 2-finger gaps, and the 25 square centimeter ballooning metrics.
We really did cover a lot.
Yeah, and if I'm listening to this, I might be feeling a little overwhelmed by all these numbers. What does all this data actually mean for determining what is normal?
I think the most important synthesis of all this data comes from a key quote in one of our physical therapy sources.
What does it say?
It states plainly, "The pelvic floor is not a hammock that is suspending in the air."
Not a hammock.
Right. Its integrity relies on the whole pelvis. It relies on how you stand, how you breathe, your genetics, and your daily activity. The MRI studies we looked at showed that some people naturally lose muscle bulk over time, or they even have an avulsion on one side, but they still function perfectly well.
Because their body's just, like, adapted around the injury.
Exactly. Normal has a wide, highly dynamic range. Just because your anatomy might fall outside a strict mathematical median, or you have a -1 instead of a -3 on a chart, it doesn't inherently mean you are broken.
That's reassuring.
Yeah, someone with naturally robust muscles might have a tear and never even know it because their surrounding tissue compensates so beautifully.
Which really is the crucial takeaway for you listening. While the POPQ coordinates and LUG measurements sound intensely precise and maybe a little intimidating, the absolute most important metric of all is often how you actually feel and function in your daily life.
100%.
The math exists to guide the doctor's treatment, but the treatment exists to improve your life, not just to fix a number on a spreadsheet.
That is beautifully said. The numbers are just a map, but you are the territory.
It really circles back to where we started. The internal pelvic floor isn't a simple static X-ray of a broken bone. It's living, breathing, moving tissue.
Absolutely.
Which leaves me with a final thought to ponder something that all this raw data kind of dances around, but doesn't explicitly answer. If our internal anatomy dynamically shifts throughout a single day, sagging heavily after a long afternoon of standing, and then miraculously retracting and recovering after a full night of sleep is normal, really a fixed anatomical destination? Or is normal actually just an ongoing, lifelong negotiation with gravity?
A lifelong negotiation indeed.
Thanks for taking the plunge with us. We'll catch you on the next deep dive.